Okay, changed on my screen. And I'm going to try and advance my slides. Yep, here we go. So goals for today are to be aware of how cancer treatment can affect sexual function, intimacy, and quality of life. To know how to get help with any of those things, and to understand how physical therapy helps cancer patients and survivors improve function and quality of life. Because there is no doubt that whether we're sexually active or not, who we are as a sexual person is still a part of our life. Why do we talk about it? Because our sexual health affects quality of life, because there's a really high incidence of sexual dysfunction. And in the healthcare community, it's really not discussed very much. And in the public community, when I suggest to my patients, would you like some information about sex, although I word it a little bit differently, a lot of times they're kind of like, why doesn't anybody ever ask me about that, right? It's hard to talk about. Also, there's a huge amount of sort of lack of information and misinformation. So many of us walk around for a large part of our lives believing stuff about sex and our pelvis and all that function, and not really having good information about it. Also, because sexuality isn't just about sex. That's why I called it Sexuality and Intimacy. Sexuality and intimacy are partly about closeness as well. And then one of my patients years ago said, I just wanted to continue to be the whole person I was before treatment. And part of that for her was to feel more comfortable as a sexual person and in her intimate life. So there's some barriers for people talking about sex, obviously. There's been a whole number of studies done on why don't people talk about it, how many people do talk about it. And in one study, 85% of people said they would like to discuss sex with their provider. About 71% of them believe that their provider doesn't want to talk about it or doesn't have the time. And we all know how that goes, right? In the healthcare world, many times our providers have 10 minutes or 15 minutes or not very much time. And so it can be hard to launch into a subject like that isn't usually a 3-minute conversation. About 68% of people believe that their provider would be embarrassed to talk about it. And if you poll providers, there's a fair number of providers that are like, yeah, I don't know how to talk about that, and it's not really my thing, and not really. And a lot of us are embarrassed to talk about it, right? It's an uncomfortable subject for many of us. In regards to providers, in a large way, a lot of physicians, nurses, even physical therapists, so people in healthcare don't really know how common it is for people to have problems with sexual function. Commonly, healthcare providers will say something like, oh, I wouldn't want to offend my patient by asking them if they're having sex, or they want to have sex, or they're having any problems. And so they might hold back on that. In general, that's a fairly unrealistic fear, but nonetheless, it happens. Time constraints, as I said, and often some lack of skills or knowledge. Again, sex isn't easy to talk about. And in general, education, I know my master's program didn't talk about sex and sexuality very much. So you really have to delve into that subject to be able to talk about it. Also, often healthcare providers are uncomfortable talking to the opposite gender, or to anybody that's less than 18 years old or more than 65 years old. If we look in the media, and if we think about it, how often do people think like, once you're X years old, like surely you're not having sex anymore, or thinking about sex, or being a sexual person? So there's all this stuff out there that prevents people from talking about it. And here we are. Oh, wrong way. What are the benefits? Well, it can reduce stress. It can cause stress as well, also. It can make us feel better. It can increase our self-esteem. It certainly brings more blood flow to the area, to whatever area is involved in sexual activity, so not just the pelvic arteries. and it can foster a sense of closeness and connection. So pretty commonly during and after cancer treatment, and we're going to talk about the side effects of that, both a patient or person and provider or partner just might not even be thinking about it, or might feel like we can't connect, I can't connect, I can't even think about it. And yet there's a sense of closeness that we get from touching or from holding hands or from any of that activity that we put under the category of sexuality and intimacy. There's a bunch of factors, as we all know, which influence who we are as sexual people. Physiologic factors, psychological factors, interpersonal relationships, sociocultural, in other words, religion, what culture we were raised in, how our parents and the people around us taught us either consciously or unconsciously to think about sex. And then communication is challenging. So, you know, people say that in relationships, what is it? Money, what's the other thing? Money and something are really hard to talk. Money is the hardest thing to talk about in a relationship. I think that sex and sexuality are way the heck up there. And so initiating a conversation even can be difficult. And I'm gonna right now give you an idea about how to do that. So I have a lot of books in my office about sex, sexuality, intimacy. And so oftentimes I'll say, hey, if you want, you can take this home, put it on the coffee table, and your partner or spouse may say, like, what is that you're reading? And it starts to make room for having a conversation. So I can't get into depth, how do you start to talk about sexuality? But there are a lot of books out there, and that may be something that you cover with your providers as well. So here we go. This is a long list on the effects of cancer treatment, changes in self-image. So again, all these things are going to affect who we are as sexual beings and in our intimate relationships. Energy level, loss of libido or desire, fatigue and deconditioning. So in some sense, if you think about it, these are all things that happen as we go through life. And in general, they're accentuated from cancer treatment. Other things are sort of the physical side effects of cancer treatment, and these happen, some of them happen to some patients, not all of them necessarily. So tight, sore joints and muscles. Many of my patients have described going through cancer treatment as like having the flu, or like a really bad flu. Vaginal atrophy and dryness. So in women, menopause normally causes symptoms like that. But chemotherapy especially, and then radiation therapy, depending on which area of the body, can contribute to that as well. Decreased erectile function for men. Bowel and bladder problems are quite common as we age, for one thing, and then as a result of cancer treatment or during cancer treatment. Hot flashes as part of menopause, and I guess I put decreased libido twice. It's kind of important. When people have had surgery, then we can have scar tissue. So in someone who's had breast cancer, then they may be very tight in their chest wall or their underarm, or even in their spine from the effects of that. From chemotherapy, primarily you can have neuropathy or numbness, or areas of your body that you can't feel as well, or you can't feel it as at all. And so then how you learn to re-experience your body in a new way is a whole adventure. Less endurance from cancer treatment. And so sex, one of my colleagues has called the sex is an endurance event. So we no matter how long it lasts. So you have to have the energy, you've got to have the cardiovascular component of health and well-being. And when you don't have that, where is the energy? Where is the feeling of like, oh yeah, we can get into this and have a good time? Weight gain or loss will change how we feel about our body and how we move in our body. Altered body image again, and then some side effects of some cancer treatments are osteoporosis. So what positions we can get into, what's safe to get into are important as well. In the realm of sex, and when we get really down into talking about sex, there's a thing that happens as we get older, that our ability to become aroused changes over time, and oftentimes that combined with reduced desire, which can come from so many things, from a long relationship that we've sort of gotten used to each other and we're like, well, yeah, whatever, you're not that interesting to me anymore. And I'm not saying that that has to happen or that always happens. I'm just acknowledging that it does. So when we get this a mixture of not so aroused, not so much desire, and we think like, right, why would I have sex, right? Or if one partner is more like, let's be intimate, and the other partner isn't. And when how we think of sex is, oh, well, I've got to be turned on to want to do anything, or I've got to be really receptive. It's useful to remind ourselves that if we start with closeness and intimacy, and we are receptive to being close with our partner, that can pave the way. So as our bodies change over the course of a lifetime or over the course of cancer treatment, to know what changes are normal and to know how do we move through that or move beyond it is part of exploring new ways of being intimate. Often orgasm potential is reduced for some people. So I've had plenty of patients, so female patients, not so much male patients, that say like, orgasm, I don't even know what that is, or I read about that, or I think I have one every once in a while. So there's so much good information out there about resources, books that one can read. There's also a fair bit of misinformation as well. But in all of this, the desire to expand your awareness and expand your knowledge and reach out and get help is really good. And then there's pain and fear of pain. So if you've been through menopause, or if you have pelvic pain, or you've had radiation therapy, it's completely realistic to think, if I try and have intercourse, I might be hurting. And in general, actually 99% of the time, we do not want pain to be part of the sexual experience. Right? For most of us, sexual experience is about pleasure and feeling good. And so we could talk a bit later about what do you do if you think you're going to have pain, or you know you're going to have pain, because it's not inevitable, and it doesn't have to be long-term forever. There are medications that inhibit sexuality, and medications are not my specialty, but this is a short little list of some things that can. And so if you're feeling like, why don't I feel like having sex, or why don't I feel like touching my partner or being touched, they can play a role as well. That doesn't mean you should go off your medication, but it does mean you can acknowledge like, oh, that's why I don't feel like it, or that's part of it, and then still work around that. Oops, wrong way. So if we could talk a little bit about caregiver or spouse or partner and their own issues about sex and intimacy. This is only part of the list about that. But oftentimes spouses or partners or caregivers are afraid they're going to hurt their partner, physically hurt them. That could be because their partner's tight, or because their partner has gone through premature menopause, or because their partner had radiation to somewhere in their pelvis, and that can produce a lot of tightness that, if it's not treated, doesn't go away on its own. They might be concerned they're asking for too much. Over the course of years of working with support groups and stuff, oftentimes on the side, partners have come up to me and said, I feel like I shouldn't ask for this. My partner is going through so much, and they're not feeling good, and they're hurting, and I don't feel like I can possibly ask to even talk about sex or talk about intimacy, because they're aware of what effect it might have, and they're concerned about that. They also might be fatigued from helping to care for their partner. So in couples or in partnerships, both people go through the experience of cancer, obviously differently from each other, but they too may feel like, I don't have the energy for sex either. And then, like all of us, they might not know how to talk about it. So starting a dialogue is really the first step. And I'm not a psychotherapist. There are psychotherapists and counselors and social workers that are experienced in this field and can give help with that. But I want to acknowledge that it's such a big part of that part of our lives that learning how or getting help with that can help to make way for conversations, and making way for conversations makes way for communication and understanding. In the case of anyone who's single, so no matter what your age, unless you're a little kid, you might be thinking, how am I going to get back into the dating scene when I feel like I do? How am I going to start over again? And at what point am I going to tell my prospective partner or prospective spouse, depending on how things move, how am I going to talk to them about what I've been through? And how are we even going to talk about how that might affect our intimacy? And obviously there's a whole lot to talk about, but same thing, like it's really good to get help with that and to recognize that life's not over in that realm. So some things that typically healthcare providers who are knowledgeable about sexuality and intimacy would ask you, but what you could ask yourself as well is, if you're sexually active, are you in the first place, and would you like to be if you're not? So that's independent of whether you have a partner or not. If you're sexually active or not, do you have pain somewhere? And if you have pain, how can you get help with that? If you have problems with bowel or bladder function, how is that going to affect sexual function? So I work with a lot of people that have problems with urine leakage or gas leakage or stool leakage or constipation. And especially in the realm of leakage, we can't easily understand that someone would be like, there's no way I'm going to have sex because what if I leak? Bowel and bladder problems are super common in the non-cancer survivor or patient population. So studies show that at least 50% of women have problems with leakage at some point in their lives, and it can tend to get worse as life goes on. For men that have had prostate cancer treatment, or for people with any of the pelvic cancers, so rectal cancer, uterine cancer, et cetera, there can be some changes to the muscles and the sphincters that impact that. Problems with lubrication are super common, both as we age, as we go through life, and again, with some of the side effects of treatment. Problems with erectile function. So same thing, there can be help for that, aside from taking Viagra and Cialis, but that's often not talked about very much. Same thing with orgasms, or if you're unable to have orgasms, how can you learn? And there are ways to learn that. And then general, do you have questions about sexual function, and who are you going to ask them of? So I know I'm bringing up a whole lot of different things that it's like either, depending on how you look at it, a treasure chest or a Pandora's box of like a whole lot of stuff that's hard to talk about. But my purpose is to bring focus to that so that you all know there's help for that stuff. So, and it's not just about, like, so many people have told me, like, just relax, but their provider has told them, just relax, you'll feel fine, right? Well, has anybody here ever felt not relaxed or upset, and your partner or your spouse or somebody, I remember, tells you, like, just relax? And that is so not helpful when you're upset or not feeling relaxed, right? Having a glass of wine might make you feel more like being in the mood or more relaxed, but it's not the end all and be all or necessarily the best solution, because sex is not just about being relaxed. Viagra for men. So clearly, like, it generally helps with erectile function, but we know sex is not just about erectile function. It's about a whole lot more than that. Erectile function for men is a huge component of being able to be sexually active, but it's not the only component. And there are protocols for after men have prostate cancer treatment for improving erectile function. And then the other thing that I've heard an awful lot from my patients is sort of like, this is especially in regards to pain or to problems that are hard to talk about, or that provider doesn't know how to talk about or doesn't have the expertise, is not uncommonly people will hear like, oh, it's all in your head, right? And so I always say to people, our brain is in our head. And our brain is so complex, and it regulates it has a lot to do with how we think and feel, both physically and emotionally and psychologically, as well as physical function. So in some sense, it's true. Someone says it like it's all in your head. You can say, well, it's in my brain, but it's also in my spinal cord and my peripheral nerves and my muscles and my blah, blah, blah. Like, so that's not really a very useful thing, usual way to think of it. I think the other thing that I really have experienced a lot with people is when we start to talk about and acknowledge that our beliefs and how we feel and what we think about sex and sexuality and intimacy, that stuff is in our head in a sense, but we are holistic, three-dimensional beings, and all of that really needs to get addressed. Again, I'm a physical therapist, so that's my primary realm of knowledge and practice. But I want to acknowledge that it's so much more complex than something as simplistic as that. Since I'm not a social worker or psychotherapist, I'm not going to get too much into this, but in regards to emotional intimacy, or really any kind of intimacy, to learn how to reconnect again after cancer treatment, to practice being honest, right? And of course, there's like brutal honesty and sort of more kind honesty, but to be open and honest with our feelings and our talk about this stuff can be really healing, actually, even though it's quite hard, especially at first, to broach the subject. So how do we have better sex, right? Raise your hand if you'd like to know. So one thing is to let go of goal-oriented approach, right? For many people, when you say sex, that means intercourse. And some of us have been brought up that way. Some of us think about that. Some of us, like, ultimately, for people, if we can't have intercourse, right, for whatever reason, then we can't have sex or we can't be intimate. And that's not necessarily true, but it's something to get past, and it's something to explore. In regards to erogenous zones, so it's pretty classic that people think, and I'm going to be quite frank here, so please excuse me, that the primary erogenous zones are the genitals and the breast, or the chest area. And I always remind people we have nerve endings all over our body. And when our sensation has been impaired in one place, we can use the nerve endings in other parts of our body to explore how is it that we enjoy our own bodies and someone else's body. It's useful to communicate likes and dislikes with our partners, but a lot of times people don't even know. Like, your partner might ask you, so what do you like? And you may or may not know really what you like. That might seem a bit odd to some of you. And then it might seem very hard to talk about to someone else as well. But it's a pretty useful thing to explore. And then if you don't really know your anatomy, there are a lot of books out there that describe anatomy. I spend a lot of time with the people I work with my pelvis model of the male and female, talking about that, because most of us aren't super well educated, especially about pelvic anatomy. So better sex, one thing in regards to more commonly in relationships that are a bit, have gone on for a bit longer, or if you have kids, or if you have a busy life, by the end of the day, and then the end of the week, and then the end of the month, you might feel like, yeah, I don't have energy for that. We don't have time for that, whatever. But it's useful to make a date with your partner and decide, maybe we're just gonna set the environment, and we're gonna light a candle, or we're gonna have some flowers, or we're gonna put on some music, or we're gonna set the environment So it's more conducive to relaxing and enjoying each other. And then by feel safe, I mean, that has a lot to do with communication with your partner and to have fun. So a number of years ago, I met the woman who at the time was really the only, she was a psychiatrist and a psychotherapist, and she'd gotten her PhD in sexuality and intimacy. And she was practicing in Honolulu. At the time I met her, I called her up and I said, hey, I do pelvic health. I'd love to talk to you because I like to be able to refer my patients to someone that's good to talk to. She's like, oh, sure, come on over, blah, blah. And I said, what would you like me to bring? Can I bring you coffee or something? And she said, I would like a chocolate cupcake with cream cheese frosting. So she like, I thought, okay. So I brought her a cupcake and we had cupcakes together. This gal kind of blew my mind in some ways. So she, at the time, I think she was maybe 83 or 85. She had a thriving practice, super well known in the area. She was probably about 4 feet, 11 inches tall, maybe. She had very severe scoliosis, so she was quite twisted and bent over, right? And she had this vitality and energy and exuberance. And one of the first things she said to me, she said, I tell all my patients, you have to have fun when you have sex. And I thought, how many of us would our mind be completely blown by someone, in a way, anyone saying that to us, especially as I said earlier, what are our sort of prejudices about once we get to a certain age, we're not a sexual being anymore? Or like, what, have fun? Like, wait a second, that's not, wait, how does one do that? So I wanted to share that story because I loved that she came at it with such a fresh, energetic, alert attitude. So of course she did a lot of education, and of course she talked to people about difficulties and so on. But what a great starting point for all of us to kind of start from and come back to in a way. So at its best, and I think this is true, certainly not just for the pelvis or sexuality or anything in healthcare, is we get the best healthcare, and as healthcare providers, we work together the best by working together. So there's medical help, there's counseling and psychotherapy, there's physical therapy, there are occupational therapists that help people with pelvic problems, acupuncture, chiropractic, naturopathy, massage, and the list kind of goes on. But I want to acknowledge that from each of those disciplines, we may find people that help us with different components of our well-being after cancer treatment and for our overall health. And so then kind of diving into physical therapy for sexual dysfunction. So if someone had told me when I graduated school 26 years ago, like, Anne, you are going to be helping people with sexual problems and pooping and peeing, I didn't even know that was a specialty at the time. And I would have told you I didn't see how that was going to happen. It wasn't my interest. So how I got interested in it was I was working with breast cancer patients, and I thought, you know, I should learn something about the bladder because a lot of them were having bladder problems. And I took a bladder rehab course, and about 2 hours into it, the 2 instructors were giving the statistics on how many women have problems with their bladder. And I was pretty distraught about that. And then talking about how few women get help and how many women think it's normal. So that was my first course in pelvic rehab. And since then, I've had a lot more practice and a lot more education, but I want to really focus partly on education because that's where we learn, that's where we're in some ways kind of freed up from our problems, from the things that bother us. So in PT, talk about, I do a lot of education. I teach people how to do Kegel exercises. And so I'm referring to strengthening of pelvic floor muscles that men and women can do, that about 50% of women, even when we read everything on the internet and we practice like crazy, about 50% of women actually do them wrong. And so they're not the end all and be all to pelvic problems. In PET, we normally do, and I do a lot of hands-on treatment for tight muscles, stiff joints, scar tissue, lymph flow and blood flow, so that to have the best possible opportunity for your body to work better in regards of how I can help that, or PTs do that, not just me. And then therapeutic exercise, which means what are the types of exercise that would help you the most? We all know we need to exercise. After cancer treatment or during cancer treatment as well, there are specific types of exercise that are helpful to address particular problems, aside from generalized exercise, walking, swimming, and so on, that we all know we need to do. I talk a lot with people about pain mechanisms because many of us, so there's a part of our brain that when we have pain, there's part of our brain that's like, don't do that. And so we don't do something because we don't know, is that a pain because I'm tight and stiff? Is it a pain because something's happening that's really bad in my body? We do a lot of behavior modification, especially in regards to bowel and bladder habits. A lot of talk about physiology and anatomy, so that as we understand our body better, we can live in it better. I'm talked to about what's the cycle for going from desire and arousal to completion. I want to emphasize sexuality isn't just about our genitals, and it's not just about sex as well. And so just a little bit of more about education, about lubricants, the types of lubricants, about the effects of cancer treatment and sexuality, what role do pelvic floor muscles play, and positions that you get into. You can get into if you can't be comfortable in certain positions, if you have osteoporosis, if you have a stiff back. So here's a little aside on lubricants. I just watched a Zoom with an Australian physical therapist who does male pelvic rehab. And I love what she said. She said, guys, remember, and she meant gals too, think of lubricants as a fun adventure to explore, not something that you have to use because you don't get wet anymore. Please excuse my frank language. So just a little bit on this. There's three primary types of lubricants. So there's oils like coconut oil that are generally safe to use but messy. There's silicone lubricants, which last longer. And then there's water-based lubricants like Slippery Stuff, Femglide. There's a bunch of stuff on the market. The water-based lubricants wear out faster and have to be replenished. I want to really emphasize that it's never good to have non-lubricated sex. There's nothing good about it. It's because it's hard on your body. It's hard on your skin and soft tissue, both for men and women. It's not good at all to use Vaseline, baby oil, or Crisco, and those are things that some people use. You may have used it, some of you. KY jelly and Astroglide and warming liquids can irritate, especially vaginal soft tissue, more than penile soft tissue. And Replens is sometimes prescribed by healthcare providers as a lubricant, but it's actually not a lubricant, it's a moisturizer. The other thing is that there's a lot of natural stuff on the market, like Good Clean Love. There's a lot of stuff that has really cool names that are all natural, and that may or may not make them a good lubricant. So it's, again, like my colleague in Australia says, like, have fun and try different things. But there's a few things there. So general benefits of exercise, you know them. Flexibility helps you move better and feel better. And if you've had cancer treatment, you may not feel very flexible. Exercise reduces your fatigue and releases endorphins. And lately, some of the research shows that you can do about 5 minutes of exercise and you don't have to be running or jogging, and you will get that endorphin release, which makes us feel better. It helps your body feel fit and toned. It improves your body image. Really the big things in regard to sexual function is it gets better blood flow everywhere. For sexual function, we need good blood flow, especially to our genitals, and we need good blood flow through our heart. I'm not going to spend a lot of time on exercise, but I'm going to talk about a couple of case studies, and then I'll give some time for questions. So these are people that I've seen in the course of my career as a pelvic PT. One was a 48-year-old breast cancer survivor. She came to me because she had right shoulder pain. She'd had a mastectomy on that side and lymph nodes removed and radiation therapy. And she couldn't lift her arm. She could go about to here and she could go about to here with her arm, and that was it. So that was her reason from her physician for sending her to therapy, and that's what she wanted to do. So I saw her for probably 6 or 8 visits, and about the second visit, when she was changing clothes, I said, yeah, I'm going to step out while you change. If you want to take a minute to look at the books on my shelf, feel free to do so. So, because I have had a bunch of books on my shelf about sexual health and intimacy, and I come back in and I'm working on her scar tissue. I'm doing a little bit of lymphatic massage, and she says, can we talk about sex? No, like, of course, what do you want to talk about? So no libido. When she had intercourse, it was painful. So she had breast cancer, not pelvic cancer, but she was taking aromatase inhibitors, which cause vaginal dryness often. And her primary reason for having sex was to satisfy her husband. And that's a common thing that people say is, I don't really have much desire, but I care for my partner. I love my partner and I want them to feel good. Right. And so there's a whole lot in that. I could talk about all that for an hour, but I won't. But anyhow, so we talked about the effects of cancer treatment. We talked about the sex cycle. If you don't have desire, how can you still set the stage to have a nice time with your partner or yourself? We talked about lubricants, and we talked about how do you talk about this? Like, how are you going to talk about it to your partner? And she was, at first, she was kind of like, I could never bring up this subject. It's too hard to talk about. I don't know what I would say. And so she took home a book, actually, and she put it on the coffee table. And of course, eventually her husband noticed and said, oh, what's this? And she said, you know what? I started reading about this. Check this out. And so it made the way for them to have a conversation. And it also was something that her husband could look at. So it was a way for him to educate himself and a way for them to get more comfortable with that. In therapy, I checked her pelvic floor muscles. We used biofeedback to help her muscles work better, did some hands-on stuff. The end result, this is totally cool. She could move her arm. That was really great. But she started having a nice time with her husband, and they started enjoying each other again. And, I made the suggestion too that they consider individual or couples counseling. That's a loaded topic for a lot of people. So I remember years ago, right, going through something hard, and my brother's like, Anne, you should have therapy. And I'm like, it's okay, I'm strong, I can do it. I'm talking to my friends, right? Where do we all come from? Some of us have had psychotherapy or counseling, and we recognize how useful it is. But for many of us, it's kind of like, yeah, no, I'm not going to talk about that stuff with anybody. So it's a big hurdle for a lot of people. It can be very difficult to find the right counselor for you and or your partner. But it is a way to normalize what's going on. It's a way to talk about what's going on, and it's a way to get professional help. Right? So we go to a doctor for medical help. We go to physical therapists for functional help and pain. We go to support groups to talk with people. And so I want to throw that in the mix. And she'd never had therapy before. Her husband at first was like, no, I'm not talking about our problems with anybody. But they actually went and just had a couple sessions and found that was a good way to have a conversation that was facilitated by somebody. Second example is a 65-year-old man who had prostate cancer treatment 4 years prior to coming to me. So he came to me because he was having some bladder urgency and felt like he wasn't emptying very well, and he had erectile function. He was having problems. Part of his treatment was radiation treatment for the prostate cancer. And in some people, there are longer term effects that don't show up until years after the cancer. his doctor had put him on a daily dose of Cialis. So Cialis is better for kind of maintenance. Usually it's given in a low dose to men. It's taken daily. It's safe to take daily. And its primary function is to increase blood flow to the genitals, because cancer treatment can impair blood flow and tight muscles can impair blood flow as well. He was using Viagra intermittently, so Viagra is more suited to sexual activity. He had never used a vacuum pump, so vacuum pump is a very helpful part of therapy and self-care after prostate cancer treatment, but it's not always a standard of care. And a lot of times men, and I'm not criticizing anybody here, please, but a lot of times men are handed a pump by someone and they're like, here, use this for erections. And there's some directions with it, but it's a bit daunting to put your penis in a pump and think like, what the heck am I supposed to do with this and know how to use it properly? So I want to acknowledge that for those of you that might be have received one and not using it, or that haven't received one and want to explore it. It's good to get help with knowing how to use that. And there are some pumps that are better than other pumps. So this patient disclosed that his wife, once she went through menopause, which had been about 15 years earlier, wasn't interested in sex at all. Right? And she, not only was she not interested in sex, but she wasn't interested in physical closeness or intimacy. And that was a difficult problem for him. So for treatment, same thing. We did education about pelvic floor anatomy, taught urge control. So in any of you have ever experienced on a regular basis, you feel like you've got to pee really bad and you think you won't get to the bathroom and maybe you don't. There's some great tricks for that to retrain your bladder. We did the other stuff with that. And then for him, I suggested that he go, same thing, individual or couples therapy. He didn't get any positive response in regards to couples therapy, but he went to individual therapy to be able to talk to someone about it. Where's my Kegels? There's supposed to be Kegels on there. So we haven't talked very much about bladder and bowel problems, which are a huge part of what I help people with. And I could do a whole session on each of those things, but that's not what we're doing today. I want to talk about how to do Kegels properly. So everybody up for learning? If you're not, you don't have to practice. I can't see you necessarily. So how you do Kegels correctly, there's two primary layers of muscle in our pelvic floor. And our pelvic floor is the area where our genitals are. It's the area where the pelvis bones come together. It's where urine and stool come out of. So that's our pelvic floor. It's not a flat thing. It's a curved floor. And generally speaking, the outer layer of muscles closes the opening. So if you can sit now and focus on the front opening where urine comes out. So again, this is for men and women to do. And imagine that you're holding back pee when you're sitting on the toilet urinating. Okay, that is not a good thing to do on a regular basis because it impairs your bladder being able to empty. So imagine closing off the flow of pee and then relaxing, because relaxing is just as important as contracting. And just try a few times. If you go to the toilet later on tonight and you're like, I wonder if I can do that. If you don't know, it's okay to practice once or twice. So you can learn like, oh, I can, or whoops, I can't. And then you know that it would be good probably to learn. But sometimes you can't shut off the flow of pee all the way because your muscles are tight and gripping all the time, or because they've been affected by surgery or radiation therapy. So get that feeling of contract and relax. And then we're going to move to what the British called the back passage. I love that. I was just in a course this weekend online, and they don't call it like your anus or your whatever. They call it your back passage, which I thought was quite poetic, actually. So you're going to move your attention back to your back passage. Right, and so that would be like holding back gas. If you felt like, I'm going to pass gas and I really don't want to right now, that feeling of contracting to hold back gas. And remember, just as important to release and relax the muscles afterwards. Okay, I teach as many people to relax their pelvic floor muscles as I do to contract them. So people have challenges with both of those things. So let's put it together, contracting the front and the back simultaneously. So for women, you might feel as you contract that second layer that you feel kind of a bit of a lift, like you're pulling the openings up and in. For men, you would feel like you're pulling the scrotum up towards your body or pulling the penis in a little bit, as if sort of like the way a turtle pulls its head into its shell. So that's part of what that second layer of muscles especially does. And both layers are integral to having good pelvic floor function. And then how about everybody, if you're comfortable standing up and trying that when you're standing, and then we'll take questions after that. So everybody stand up. If you can, stand up. I want you to experience this way. Okay. So stand, you could stand, if you're comfortable, you could have your feet farther apart, or you could have your feet close together. But standing, gravity pulls down on stuff. We all know that, especially the older we get. Okay. So standing, if you contract around the front opening and the back opening, so feel closing, lifting, maybe, maybe not. Plenty of people can't feel that. And then resting and relaxing. And if you're a person who has problems with leakage, you might think there's no way I'm going to relax because then I'm going to leak. And actually, unfortunately, that contributes to the problem. And people that walk around with their pelvic floors kind of tight all the time because they've leaked and they don't want to leak anymore will actually sometimes have more leakage because of that, because it fatigues the muscle and they can't keep the opening closed so that stuff won't come out. And that's my bit on Kegels. Do people have questions? I want to thank you all for attending and being curious about this. I have information. I'll put a last slide up. If anybody wants to contact me, I'm happy to be a resource for people. I am passionate about this subject, and I would rather be able to steer people in a direction or to answer some questions via email or whatever than have you not know where to go with it. So please feel welcome to do that. But I'll take questions and if anybody has any.